Well, we have the opportunity to visit with Georg Behrens, who's from Hanover University in Hanover, Germany, and we're here at the 21st CROI, and we're really appreciative you come by because we're going to talk a little bit about inflammation. We're going to do several programs on inflammation because it is so impactful, we think, in HIV. And can you give us a background on it? Let's set us up for what inflammation, what we know about it today.
I think the crucial studies were in the mid-2000, 2005, when the idea of the damage of HIV infection leading to damage in the gut and the microbial translocation hypothesis, meaning that there is a barrier damage in the gut because of the HIV infection that leads to chronic inflammation, spillover of bacterial products into the circulation, and that this causes a chronic immune activation. You know, inflammation is a very difficult term, but it stimulates the immune system in all different parts of the body. And then it starts to emerge to start to explain how some of these immune stimulation could contribute to organ damage, like cardiovascular disease, like osteoporosis, which we know from other inflammatory diseases as well, where in rheumatoid arthritis you have more increased risk for osteoporosis, you have an increased risk for cardiovascular disease as well. And so the last years were really focused on to better understand what is the cause, what does HIV do in terms of replication and the virus itself, and what is the damage to the immune system resulting from this replication and this chronic immune stimulation. And now the research, and particularly this year at the CROI, is more focused on to understand what is the damage, for instance, in the brain, you know, CNS inflammation, dementia development, and there are quite a few studies that have not yet, don't have the cross-sectional design anymore, rather than a prospective design to study patients very early on during their infection to see is there an initial damage already or surrogates for immune stimulation that could explain chronic damage in different organs.
And you have, we were talking earlier, there's a certain standard, simple markers, biomarkers that we have, and then there's some kind of unique or more tedious or complicated markers. And we're trying to say, and you were saying complicated, but yet maybe putting together might make them more robust in what we learn from them?
Yes. So we know a couple of biomarkers, surrogate markers, that tell us if we find them increased, this is a readout for immune stimulation or inflammation. Many of these biomarkers have been, investigated in other inflammatory diseases as well and are just adapted to HIV as well. Some of them are rather robust and tell us, yes, there is activation of leukocytes and so on. And many of them, because of the research to find new ones and unique ones, which are valuable to predict clinical outcomes, are results from biomarker research, from proteomics and other approaches. And through this, we identify new molecules which are somewhere in the chain of an event of inflammation. So if we find them increase, that is a surrogate for telling us they're at the very beginning of this chain, an inflammatory cell is activated. And there are different approaches. Either you find the magic one that really tells you this is increased and it tells us something, or you try to combine different biomarkers which are changed. You can use biomarkers in those situations even if they are decreased, so things can be lower as compared to other patient groups, and this is a mathematical approach to combine this. It works in some situations. Very often the limitation is that you generate the data for the biomarkers in one group of patients, and then you transform the predictive value into another group, and then it fails.
So it won't correlate with the other.
Exactly. So that is something where for many biomarkers as well as for genetic risk factors, we've learned over the last years we need to have very strong and tough conditions in which we test them, not only to, get them out of different cohorts, but rather than to apply them in independent cohorts, whether they have a predictive value or not.
So how do we take what we know, and maybe what we know we need to know, and make that translate into something that we can use as people who are living with this disease? And, where are we headed? I guess that's the best question.
So what we see on this conference and also on the previous conferences, there is an increased knowledge and information on inflammation and immune stimulation contributes to several of the organ manifestations that we see in patients with HIV infection, like osteoporosis, like dementia, probably depression. There are new studies here as well. And that this damage not only happens over the long term, but rather starts really from the very beginning of the infection.
Mm-hmm.
And then
profoundly, I think.
and profound effect. And that of course, steers up all the discussions of when to start HIV therapy. Because the best we can do to stop HIV-associated inflammation, as it seems, is to treat HIV. Mm-hmm. If we stop the replication of the virus, we can achieve a lot. The even bigger question is, can we achieve something beyond this? Because we see, even if we use current HIV therapy, there is a remaining
low
level of inflammation. And to treat this and to argue and to justify any intervention on that, to prevent an outcome, that's the big challenge. And that's what we haven't achieved. I don't see anything new on this field here at the conference, but still the information that we get about the connection between the immune system and the immune stimulation and organ damage is increasing a lot, particularly with ZNS, so central nervous system associated damage in the long term.
I don't think we've ever had a doctor that said, don't exercise or eat bad foods. So that's kind of a given. And of course there's things that we know that can contribute to, like smoking or excessive drinking or those things. So maybe those are the first instructive things that someone like yourself could throw out there as kind of a no-brainer.
I know, yeah, that's what you have to say, but we need to be honest, This is, it doesn't work, not all patients can follow this. Mm-hmm. So what's the alternative? And some would say, yes, we use anti-inflammatory drugs, we use in cardiovascular disease, which is an inflammatory disease as well. Mm-hmm. We use lipid-lowering drugs, which have also some bystander effects and have an anti-inflammatory component. Mm-hmm. Using aspirin also has an anti-inflammatory component. And we still don't know which one is more important, stopping blood coagulation or inflammation. So the approach would be, take a pill to replace any exercise that you need to do, and we don't have that magic pill. And that's also the issue I have to say, just start HIV treatment in every patient as soon as he's diagnosed. Well, that's an easy approach in terms of, we give a pill and then we cover everything. I'm not sure whether that's the best one. We need to continue to work also on behavioral things. Doing exercise, we discussed that. There is a study here looking at this, whether that has an impact on inflammation. Again, as a surrogate, that's something we should study more, and a few other interventions that could help.
These are things which aren't really, I don't know, they're real sexy in the minds of people who are living with HIV, because they're things that they think they can actually do. And if people are really proactive with their health, and they say, what can I do? I'll really do anything. And there are people who say, well, I'll just give up and I don't think I'll do anything. And so it's a whole bag of different personalities, like interventions that may or may not happen based upon the behavioral conditions of any particular individual. But there are those things that we need to study, and maybe that's what, maybe there is a little bit of a disappointment in my mind, and maybe in yours, that we don't really have as much as maybe being studied, because it's not really, it's science, but it's not really something that people want to do. It's what they used to call alternative,
Right, yeah, exactly. Yeah, and yes, but I think there is a lot of science. If you look outside HIV now, all the increasing understanding of how the bacteria in the gut have an impact on the immune system in many other diseases, and how diet impacts the composition of the different microbia in the gut, and how that has an impact on other diseases. That is an enormous increase of knowledge. We don't understand everything completely in this, but that gives us, information on what could potentially be done in the long term, and how dietary interventions could be more specifically done, not just saying eat less fat or things, rather than have a more balanced diet of this and other things. And there are already some trials looking for probiotic treatments in HIV-infected patients, whether that decreases systemic inflammation. And along these lines, I think we have more focused and more guided information that we can use in the future.
So the research that's being done, as you say, outside of HIV would be just as relevant, except maybe nice to replicate and specify as far as HIV as well.
That to me was, that's why I started with the microbial translocation thing, which came out of the gut damage idea. This has also influenced other parts of the research outside HIV, and now it comes back, because now we have technologies to measure the composition of all these bacteria. That wasn't possible 10 years ago.
Right.
And we get completely new and absolutely surprising information out of this. Some people say, well, this is just confirming what we knew before, but now we get a better understanding of how it works and how important apparently the immune system in the gut is.
I don't mean to take anything away from you, because you are older as I am, but a lot of the younger people coming into the field see it from a different perspective, and I think that new blood helps to invigorate some of the things, like you say, that they're learning in school that are given for them, that we're just coming along down the pike, and so you think, oh, we should have reinvestigated this because now we know this or this.
Absolutely.
Together, those things now give us information that we can now do these bits of research.
Yes.
And so I think that's where the young investigators come in. They have these bright new ideas, but yet you say, oh yeah, we should have done that. We should have reinvestigated that particular compound.
Absolutely. I think HIV could be, I'm always saying that this is a leading field of research, getting in new ideas, and we do see that now in vaccine research with neutralizing antibodies. We do see that also with microbiome analysis and the importance of the gut immune system for HIV and systemic inflammation. And this research really, guides then other fields as well, and gets, the technical equipment from other fields. And it's fascinating to see that people doing research in HIV are very often open for these new ideas coming from outside the field.
You find that you probably see other paradigms or other fields of study, but it seems to me like the best and the brightest gravitate here, because it's so complicated. People that are bright don't want to go to an easy field. I think they want to go to something complicated. Is that not so?
Yeah, well, that's probably also, the holy grail is cure HIV. Still on here at CROI, it's a big thing where we, we don't make big advantage within a year, of course, but things are being confirmed, and that it's more solid, and there is more strategy towards when to start treatment, to focus on those very early in infection. A lot of data now on infants and babies. A year ago I thought this is, well, does it really help us? No, it helps us. It's a completely different seeding of the virus very early in childhood, a different composition of different cell types. And it's fascinating to see how quickly, within 2 years, different models of monkey models, human observations, mouse models really work together, and there is still new hypotheses and new ideas coming out. It's really challenging, but it's fascinating. The speed of, not translational research, what we can immediately apply, but the speed of increase of knowledge is still fascinating.
I think the important thing, and this is something I should say about what we've been doing over the last 15 years in this program, repeating with different investigators year after year. And it's always interesting for them to look back, and we're building our archive again of our programs over the years, how different their perspectives were. And science is always changing. That's
Yes,
the amazing
yeah.
thing. The only constant is change. So it's really interesting for a person to look back on their views. And it was what we knew then.
Yeah, that's true. But absolutely, if you now look on this topic, inflammation and systemic immune activation, if you then talk to people in other fields like I said, rheumatoid arthritis or other rheumatoid diseases or autoimmune diseases, they would say, we know this for a long time. Systemic inflammation, increased levels for TNF-alpha, interferons, whatever, we know is contributing to organ damage, to cardiovascular disease. And if you ask them, what can you do about it? Well, the main thing is the priority to treat the underlying disease first.
Right.
And then in some diseases, like, again, rheumatoid arthritis, you give broad-acting anti-inflammatory drugs, like corticosteroids and a few others, which have an impact on other inflammatory processes, not only the joints, and thereby you have an impact beyond that organ or just the bones. In HIV, we treat only the virus to start with. And, you know, that has a positive impact on the inflammatory response, but there is a remaining fire which we don't know to treat. We have relatively good surrogates that tells us there is a fire going on, but we have nothing that specifically extinguishes it. And the big question is always, even if you do, what is the clear benefit for the patient? How many patients do you need to treat in whatever way of intervention to prevent what outcome? And that's difficult.
You need that long-term research in a person, not just person years. Yeah.
And then you need person years, you need a long follow-up, and we're not yet used to these big studies in HIV-infected patients. You know, these sort of studies outside HIV include 10, 20,000 patients to show intervention on cardiovascular disease and outcomes. And we're not ready for this because there are a few more immediate issues that we have. And
I think we need to visit with you another 3 or 4 years and see where. Then we'll play this interview, and then we'll play. This is what we learned since then.
Right.
That would be a great.
That would be definitely something that we can more name, and it would be definitely great to see that more of this research is really critically looked at and used in implications either in clinical practice or prospectively in clinical trials.
I'm going to hold you to that. We're going to visit with you in 3 or 4 years.
My pleasure.
Thank you, George.
You're welcome.
Appreciate
Thank
it.
you.